I can do the bipolar and then you can do the.
Okay.
Okay.
Go ahead.
So for the bipolar one, basically what is the criteria in the bipolar one? If there is one manic episode, then we can diagnose the bipolar one. That is the basic thing to remember, in which at least one manic episode has occurred. If manic episode leads to hospitalization or if there are psychotic symptoms, the diagnosis is bipolar 1. So in the bipolar one, it is important to remember one manic episode and then the patient can be diagnosed as bipolar 1, commonly accompanied by at least one like major depressive episode, but it is not required for diagnosis. So the major depressive episode can be present, but we don't need that one to diagnose the bipolar 1. For the diagnosis, we only need the one manic episode, right? And then time spent in mood episodes 53% asymptomatic, 32% depressed, 9%. So this is the like how the mood is present, right? So maybe there is like no mood symptoms, 53% the patient is asymptomatic, like there is no mood symptom, only one manic episode, right? Or the patient can be depressed, as they have said here. It is commonly accompanied, but maybe the depressed episode is not present, but it is 32. And then it can be hypomanic and the mixed. So these different moods can be present in the bipolar 1, but this manic episode should be there. And in the bipolar 2 disorder, what's happening? The disorder in which there is at least one major depressive, one hypomanic, and no manic episodes. So the important thing to remember, in bipolar 1 there is manic episode, in the bipolar 2 there is no manic episode, but there is one hypomanic. So one hypomanic and one major depressive, bipolar 2, only one manic, bipolar 1. So the hypomania is less severe than mania, as it is like hypo, so it is less severe. Bipolar 2 is not a milder form of bipolar 1, so this is not the milder form, it is completely different. Time spent in mood episodes 46% it is asymptomatic, 50% it is depressed, and this and hypomania. So 50% the patient is depressed. So that's why it's like, because it's like one major depressive, right? So bipolar 2 is often missed due to severity and chronicity of depressive episodes and low rates of spontaneous reporting and recognition of hypomanic episodes. So bipolar 2, because the patient's hypomanic episodes can be easily not diagnosed, so that's why it is hard to diagnose the bipolar 2. So bipolar 2 is quite often missed, and many patients are symptomatic for up to a decade before accurate diagnosis and treatment, because 50% are depressed. So they diagnose them as major depressive disorder, and then the hypomanic episode is not diagnosed. So it is often missed. Patients with bipolar disorder are at a higher risk of suicide when they switch from mania to depression, especially as they become aware of consequence of the behavior during the manic episode. And then classification, bipolar 2, bipolar 1, current or most recent mood disorder, um, manic, hypomanic, depressed, anxious, and these all can be present. And melancholic features, atypical mood congruent. So these are the rapid cycling, seasonal pattern, peripartum onset. So these are the different types that can be present with the mood episodes. And lithium is among few agents with proven efficacy in preventing suicide attempts and completion. So this is like a rare thing, but lithium is has the proven efficacy in preventing suicide and attempts and completion. And then monotherapy with antidepressants should be avoided in patients with bipolar depression, as patients can switch from depression into mania, because in the bipolar there is depression and mania. So that's why the monotherapies only with the antidepressants should be avoided, because the patient can go from depression to mania. And then the risk factor, 60 to 65% have family history of major mood disorder. So this is very important to rule out the family history. And what are the four L's of bipolar depression? Four L's. So lithium, lamotrigine, lurasidone, and seroquel. So seroquel. So these are 4L drugs that are given. So these are the risk factors. Now, how we will treat? The first thing is like as in all the disorders, we are doing the lifestyle, psychoeducation, and then ensure regular check-ins, develop early warning, emergency plans. All these all are included. And in the drugs, we are the first line is lithium, anticonvulsants, antipsychotics, ECT if resistant, and then monotherapy should be of the antidepressants should be avoided because the patient can go to mania. And then mood stabilizers in vary in their ability to treat, reduce symptoms acutely, or stabilize, prevent relapse. Manic and depressive episodes, multi-agent therapy is common. So how we will treat treat mania. So it is lithium, Devalprix, carbamazepine is the second line, but the first line is lithium. And then SGA and ECT is the second line, and then benzos are given for acute agitation. So in the mania, for the acute agitated patient, benzos are given. And preventing mania, same as above, but usually at lower dose, minus ECT and benzos. So that is kind of the maintenance therapy. And then treating depression, lithium, lurasidone, quetiapine, lamotrigine, antidepressant, second line only with mood stabilizers because we are not using the antidepressants as a monotherapy. So we are giving the as a second line only with mood stabilizers. And then second line is ECT. And then preventing depression, same as above, but ariprazole, Devalprex, quetiapine is the first line in treating bipolar 2 depression. So this is just to remember. And then mixed episode, rapid cycling, multi-agent therapy. So it is a lot to remember, but like the main one is like the lithium, and ECT is like the treatment resistant, and then the quetiapine is the first line for the bipolar 2 depression. And the psychological therapy, CBT, and all the family therapies, then vocational rehabilitation, leave of absence, and all this, then we can do that. And then course and prognosis is like in all the psychiatric disorders, there is like high suicidal rate. Bipolar 1 and 2 disorders are chronic condition with relapsing and remitting course, featuring alternating manic and depressive episodes. Depressive symptoms tend to occur more frequently and last longer than manic symptoms. So that's why the manic episodes are not that much present. So it is like easily misdiagnosed. And then can achieve high level of functioning between episodes, may switch rapidly between depression and mania without any period of euthymia in between, and high recurrence rate of mania, 90% will have a subsequent episode in next 5 years. And long term follow up for bipolar 1, so because there is like relapse and remission and all those things are happening. So that is basically it for the bipolar 1. And then the last one is cyclothymia. Presence of numerous episodes of hypomania and depressive symptoms not meeting criteria for full hypomania or MDE for more than 2 years. So the hypomania and MDE symptoms are not like the criteria is not met, but there are numerous symptoms of hypomania and depressive episodes for 2 years. So the previous the dysthymia that was for 2 years also, and this cyclothymia is also for 2 years, but it has hypomania and depressive symptoms, but never without symptom for more than 2 months, have never met criteria for MDE, manic or hypomanic. So basically all the previous ones, the criteria are not met, then they put it here. And symptoms are not due to direct psychological effect of substance or GMC, like any medical condition or substance use. And symptoms use clinically significant distress or impairment in social, occupational, so there are like clinically significant distress is present in cyclothymia. And then treatment is similar to bipolar 1, mood stabilizer, and psychotherapy. So these were all the mood disorders.